Hello, my name is Haneen, and in this presentation, we will discuss how ECT has been improved upon over the last 50 years and some of the advantages and disadvantages of this treatment. Just to give a quick overview, I will first start by giving a brief introduction to ECT and talk a little bit about why this area is important to focus on at the present time. I will then explain how ECT has developed over time and talk about the main advantages and disadvantages of the treatment. Finally, I will end the talk with some concluding thoughts and future directions of research. Electroconvulsive therapy, or ECT, is a procedure done under general anesthesia in which small electric currents are passed through the brain, intentionally triggering a brief seizure that lasts for 30 to 60 seconds. And it's thought that this seizure is crucial to the efficacy of the procedure, and it's usually administered for 6 to 12 treatment sessions. Now, the exact mechanism by which ECT alleviates symptoms is currently unknown and debated. So, who is ECT used for? According to NICE guidelines, ECT is used for the improvement of severe symptoms in people with catatonia, prolonged or severe manic episodes, and depression. The decision to use ECT is based on patient preference, when a rapid response is needed, or when other treatments have been unsuccessful. As we can see here, in the NICE stepped care model for depression treatment, pharmacological and psychological therapies are usually considered as the first-line treatment, whereas ECT is only recommended in the final step for patients with severe life-threatening depression or when treatment in the previous steps have failed to alleviate the symptoms. Before discussing the evidence for the use of ECT, it's helpful to think about the key reasons of why addressing this area of research is important. Firstly, it's useful to reflect on the development of ECT over time and acknowledge how current procedures have evolved. This is because a large amount of stigma that exists around using ECT in clinical practice largely stems from controversial ECT procedure done in its infancy, and this stigma is maintained throughout unhelpful media representation. So in the media, we have news articles, and ECT is frequently portrayed as a form of involuntary torture stemming from less regulated ECT procedures from the 1930s. For example, this article by The Independent recently in 2022 depicts ECT as a dangerous electric shock rather than a highly effective treatment for vulnerable groups of patients. We also see this kind of representation in movies and TV. This study highlights depictions of ECT in film and television, and the review found that around 80% of scenes showed ECT as being used for mind control and was portrayed as a memory-erasing, painful, and damaging procedure. So raising awareness of how clinical procedures have been modified to suit stricter modern-day guidelines could help the impact of stigma on patient treatment choice and the provision of and referral to ECT. So where has this negative representation of ECT come from, and how do the practices differ today? So in the early 1930s, chemical seizures were used in psychotic patients, which led to sufficient recovery for the patients to leave the hospitals. Rapid developments in technology in the years to come gave easier and less expensive opportunity to create electrically induced seizures. Later on in the 1950s, anesthesia methods were introduced to reduce discomfort and control muscle movements. So before the 1980s, bilateral electrode placement was the most commonly used, so electrodes placed on both sides of the head. Since then, randomized trials have since shown that right unilateral ECT can be as effective and has less cognitive impairments. So in continued attempt to further improve efficacy while minimizing effects in the present day, more recent evidence suggests the use of ultra-brief pulses, which I will discuss later on. Okay, so that was a quick overview of the development of ECT. Now, with regard to the improvements upon ECT in the past 50 years, there were three main changes. Firstly, it's important to mention that the use of anesthesia and muscle relaxants during ECT has now become standard practice. So this includes using short-term medications for induction and maintenance of anesthesia and muscle relaxants to avoid any musculoskeletal injuries. Now, in terms of administration, there are several improvements. For pulse width, I just wanted to show an example for a better picture. So this slide just shows the development and improvement in pulse width. So in the 1970s, sine wave electrical stimulus were used and these used longer pulse widths, so about 8 milliseconds, and these often resulted in substantial cognitive effects. Now, however, we've utilized ultra-brief pulses, which have much shorter pulse width, and these are associated with reduced cognitive deficits. A second improvement in ECT administration is electrode placement, as we have mentioned, and these aim at increasing therapeutic effectiveness. Advances in dosing techniques have also allowed for more precise and individualized dosing in ECT. Thirdly, monitoring and evaluation standards are now overseen by organizational bodies, such as the Electroconvulsive Therapy Accreditation Service in the UK, which works to ensure that ECT treatment centers meet and maintain high standards of care, safety, and effectiveness in the delivery of ECT. Now, moving on to the advantages and disadvantages of ECT, two of the main advantages of ECT compared to other treatments is its efficacy and ability to reduce suicidality. With regards to efficacy, some researchers have argued that there is no longer a need to prove its effectiveness. With the evidence accumulated over the last 80 years, it is the most effective treatment for severe depressive disorder. However, let's have a quick look at some of the evidence for this. So a meta-analysis including 6 randomized controlled trials comparing ECT with sham treatment revealed an effect size of 0.91 for ECT. However, a recent review argued that in many of these meta-analyses looking at studies comparing ECT to sham, the meta-analyses pay little or no attention to the multiple limitations of the studies they include, such as the processes of randomization and blinding and small sample sizes. Now, in a study looking at major depressive disorder, 34% achieved remission by the 6th treatment and 75% remitted by the 10th treatment. ECT also offers advantages over antidepressive treatments. So Pagnon and colleagues performed a comprehensive meta-analysis comparing ECT with various antidepressant medications, and ECT demonstrated significantly greater likelihood of improvement compared to serotonin reuptake inhibitors and other medications. Recent studies have also suggested that response rates can be further improved in the ECT plus antidepressant group compared to ECT group alone. Importantly, ECT is particularly beneficial for individuals who have treatment-resistant depression, defined as the failure to respond to 2 adequate dose and duration antidepressant medication trials. Treatment-resistant depression occurs in almost 30% of people with major depressive disorder. Therefore, ECT can be a life-saving option for those who are severely depressed and at risk of self-harm or suicide. A meta-analysis of cohorts studied noted a remission rate of almost 48% in patients with treatment-resistant depression. However, long-term outcomes were not assessed in these studies. Another advantage of ECT is its ability to reduce suicidality. A cohort studies following ECT in patients with unipolar depression or bipolar compared ECT versus non-ECT controls, and the primary outcome was suicidal events. They found that ECT recipients showed a 19.7% lower risk of suicide than control individuals. It can be argued, however, that this study did not use a comprehensive assessment of suicidality. Suicidal events are specific instances where individuals attempt or complete suicide, but they may not capture the full range of suicidal thoughts, ideations, or behaviors. Instead, they may include standardized questionnaires, clinical interviews, and assessments of suicidal thoughts or behaviors. So moving on to some of the disadvantages of the treatment, these include high relapse rate, cognitive impairment, and stigma. Firstly, an important disadvantage is poor relapse rates. A systematic review and meta-analysis looked at relapse rates following successful ECT. When looking at relapse rates following placebo treatment, so there's no expected benefit really, they found high rates with 62.7% at 3 months and 78% at 6 months follow-up. For patients who are on pharmacotherapy, we see a slight reduction. However, a 12-month relapse is almost 51.5%. Now, one of the reasons why the post-ECT relapse rates are so high, despite continuation on pharmacotherapy, is that ECT is most commonly prescribed to patients who do not respond well to pharmacotherapy trials. So some researchers have argued that if medication did not work well before ECT, there is no compelling reason to believe that they will work well after ECT. More recent investigations have looked at lithium as a continuation treatment and found that it was associated with significantly lower relapse rate when compared to other continuation therapies. However, systematic reviews looking at lithium for relapse rate prevention following ECT have reported the low quality of studies and suggested high quality studies are needed to confirm these findings. Secondly, one of the main reasons ECT might be avoided by patients is the risk of cognitive impairment. A recent systematic review and meta-analysis looking at short and long-term cognitive effects used standardized cognitive tests and separated them into 11 cognitive domains, and these are presented on the screen. So the researchers compared between pre-ECT measures, so at baseline, and at 3 different time points after, so immediately after, short-term, and long-term. So what they found was that at the first time point, ECT had no impact on global cognitive function, and this was measured with the MMSE. And there was no sufficient data to examine the effects of ECT on any other cognitive domains, so this is one of the limitations. Second time point, however, post-ECT performances were significantly worse relative to pre-ECT in autobiographical memory, verbal fluency, and verbal memory. Effect size estimates were small to moderate in all these 3 cases. Now, this is in line with other research suggesting that adverse effect of ECT on autobiographical memory. Interestingly, for long-term results, cognitive performances had significantly improved compared with pre-ECT for all the ones marked with the triangles. So executive functioning, visual memory, verbal memory. Now, it's important to question whether these improvements were a result of ECT or a consequence of depressive symptom alleviation. Now, although these findings suggest no impact of ECT on long-term autobiographical memory, analysis from other studies report different results. Now, the researchers highlight this and argue that these variations could be due in part to the ECT parameters used. So, like we discussed, sine waves used previously were consistently associated with worse cognitive adverse effects. Another important consideration is that this meta-analysis included studies which had low to moderate quality. Moreover, it did not consider subjective ratings, which may have biased the results. Now, discrepancies persist between objective and subjective tests, and previous reviews based on subjective evaluations agree that some form of autobiographical memory effects are present immediately after treatment, with the percentage of individuals affected with long-term memory loss varying between studies. The last disadvantage I want to talk about is stigma. And to truly understand the impact of stigma, it's important to refer to qualitative studies that capture the experience of individuals. So interviews conducted with patients who were considering or already receiving ECT reveal that they often expressed concerns about potential memory loss and cited this as their primary worry. However, previous discussions have indicated that evidence suggests that any memory deficits that may occur are typically temporary and not long-term. Therefore, this patient's apprehension may have been influenced by negative stereotypes and perpetuated by the media. And once a patient has undergone the treatment, and even if they have benefited from it, they still face stigma from the views of others. Like this, for example, one participant expresses feelings of shame about mentioning ECT to her children because it seems extreme and frightening for most people. And so, circling back to the idea of misinterpretation and stigma in the media, another study reports that participants were reluctant to engage in ECT, and in this example quote here, because of the horrifying images presented in the movie One Flew Over the Cuckoo's Nest, in the image I showed earlier on in the slides. So what directions should future research take given what we currently know about ECT? So firstly, it may be helpful to observe how people respond to more accurate representations of ECT in the media and how this could potentially affect their judgment, as this could help push more accurate depictions of ECT to circulate in the media. And as previously mentioned, studies investigating autobiographical memory may also help alleviate the stigma. Now, in line with this, as we've discussed, there has been little research into the more qualitative subjective experience research, which could be helpful to understand the impact of ECT. Adding on to this is more research into reducing relapse rates after ECT. Thank you so much for listening. These are my references, and if you have any questions, please feel free to email me.